Okay, thank you for joining me in this discussion about pulmonary hypertension. So, this is my lovely square heart that I learned to draw in nursing school, but I just think it's a more simplistic way. And so I'm going to start by talking about what should happen in our fetal circulation in utero. So we would have our blood coming from the body, goes to the right atrium, right ventricle, and then it can go up to the lungs like how it normally would. But in utero, our lungs are largely collapsed and filled with fluid. So that's a really high pressure environment. And blood is always going to take the path of least resistance to lower pressure from higher pressure. And so as our blood goes, because this is so high, some of it might shunt through our foraminal valley, and a lot of it might shunt through our ductus arteriosus here, in just bypassing the lungs straight into the aorta. And so largely because we don't oxygenate in utero with our lungs. They're filled with fluid. So we oxygenate by the placenta, and so that's why this system makes a lot of sense and is totally necessary. So after birth, our lung fluid is absorbed during labor and then the birth process and our first breaths after birth. And so that should replace a lot of this fluid with air, which is going to create a much lower resistance circuit. So because of this, and then also oxygen is a potent vasodilator. And so if you can imagine blood going through a much tinier vessel, that's going to have a lot of pressure. Versus if we have a much bigger vessel, then it has a little bit more room, and that's going to be a lot less resistance. So this pulmonary vascular resistance should be going down after birth. And because this is going to be so much lower, we could go through our foraminal valley, but we sort of don't, because this is a low pressure environment that we're going to go to. And we could go through our ductus arteriosus, but this is higher pressure over here, so we're still going to go to our lungs and then get oxygenated and come back around and do our normal thing. However, sometimes our PVR doesn't go down after birth for a variety of reasons, and it stays increased. And so that could be retained fetal lung fluid, like TTN, or that could be RDS, really bad, meconium, because we have little specks of meconium literally covering our lungs. It could be an infection like sepsis or pneumonia. Any of those things can stop the drop of our pulmonary pressures. And so if they stay elevated, then what do we think is going to happen? That's right, we're going to shunt. And so if we still have our high pulmonary pressures in our extrauterine environment, we're going to go, our deoxygenated blood goes our normal routes. But because this pressure is still really high, a lot of this blood is going to shunt. It's going to shunt to lower pressure. But some of it goes to the lungs, hopefully, and gets oxygenated. And that nice pink blood's going to come back down like this. But as you can see, now it's going to mix with our deoxygenated blood. And so this becomes a problem because we are not able to oxygenate our tissues as well if we have mixed deoxygenated and oxygenated blood. One thing I want to talk about here, and so this is pulmonary hypertension. And so the higher these pressures get, the more shunting we're going to have. And that's going to be our right to left shunt. And that's our deoxygenated blood going into our systemic circulation. Of note, there is a branch called the brachiocephalic that comes off normally right after or before the ductus arteriosus attaches to our aorta. And so why that is significant is our brachiocephalic supplies our subclavian, which is going to be like our right arm, right hand. Know where I'm going with this. And also our right head, sort of right face. That's the cephalic part. And so down here, the rest of this is going to our sort of maybe not as oxygenated body. So when we do a pre and post ductal sat, that is why we're looking at our right limb versus our feet, because we're going to have, if we do have this right to left shunt, we're going to have a pretty big difference between what our right arm is saying, because it's going to be our less mixed blood, though of note it could potentially mix here too, versus our more mixed blood down in our feet. So if we have this big difference, then we can tell that we probably have high pulmonary pressures in a right to left shunt. So some of the ways that we can try to help this baby is by, one, solving our etiology. So if we think that this baby has pneumonia or RDS, we can give maybe some surfactant, and we can provide oxygen, of course, because oxygen's that vasodilator. If it's infection, we would give antibiotics, that sort of thing. And we want to give this baby as much oxygen as they need because of that vasodilation process. So we want to keep these babies generally like above 94%. Another way that we can help this baby is, if you can imagine, if we're crying and we're upset, then that's going to bring this vascular resistance even higher, and that's going to create more shunting. So for these babies, if it's a really bad shunt, we will try to sedate them or give them proper pain management and keep them in a quiet, dimly lit, comfortable environment, not mess around with them too much. And then another thing we could do, obviously, conventional ventilation, oscillators, even CPAP if it's a little bit less of a shunt. But we could give nitric, which is what we're here to talk about. And so nitric is also a vasodilator, and when it's inhaled, it's really going to specifically address our pulmonary tissues versus our systemic blood pressure, because we actually want to keep this systemic blood pressure relatively high, but not too high, but definitely not low. And so it's really good to have something that affects just our pulmonary vasculature so that we can decrease this PVR and keep our systemic blood pressure okay. And so I hope that wasn't too confusing. Hopefully this all made sense and we can better understand how nitric helps us with our PPHN babies. Thank you for watching.